Well, my name is Eric Jones. Joined the military in 1969.
Hi, I'm Monica Lewis Jones. You're with my husband, Eric Jones. We have been married for over 30 years.
35.
35?
Something like that.
Something like that. We have a tremendous blended family of 5 children and 10 grandchildren.
I was with the 1st Infantry Division in the southern part of South Vietnam. It was quite an experience knowing what you're walking into. I was really feeling real tired, and I was losing a lot of weight. Monica said, Eric, come on, we need to go to the doctor.
I'm Ravi Parikh. I am a medical oncologist here at the Philadelphia VA Medical Center. The VA, part of its core mission, has a goal of providing the exact same level of high-quality care to every single veteran that walks through its doors.
Coming to the VA for 30-some years, my primary care person was very familiar with me, and she said, oh, something must be wrong, your wife is here. She ordered me to take a chest x-ray. So she said, Mr. Jones, you have lung cancer. I said, oh my goodness. So she said, have you been having any headaches or anything of that nature? And I was. She said, well, I want you to take a MRI. So they take the MRI and it comes back. I found out that I have a tumor on my brain. And you can't go home tonight. We have to admit you in the hospital right away.
I met Eric. He walked into the office. I explained what we saw on the MRI, and I said, we need to get you over to the emergency room and then to a neurosurgery service. Now, outside of the VA, this would have been difficult, and Eric had his surgery the next day. He had a particular type of lung cancer. We treated it aggressively with a combination of radiation and chemotherapy, and then subsequently to that, he's been on immunotherapy, and his disease hasn't progressed. What health equity means is making sure that every patient, no matter race, creed, ethnicity, socioeconomic status, where they live, can have access or has the chance to have access to those therapies.
I came to every appointment. I came to...
Every appointment.
Dr. Parikh was amazing. He and I were in communication. He was just amazing throughout the journey. And I have to give him accolades for helping to get us through that.
The VA is great for veterans because where we excel is that we're providing comprehensive care. So the goal of VA is to go out and make sure that everyone has equal access to care regardless of where they live. At the VA medical centers, they may not necessarily have oncology, the full breadth of oncology services. And so when we have national tele-oncology, we are seeking to identify which VA medical centers may not have the full breadth of oncology services and deliver disease-specific expertise to those teams. Having that all-hands-on-deck team is critical towards making sure our patients have this wraparound approach towards addressing their needs.
So many of the drugs coming on the market now are oral, and patients can take these at home without having to come into the clinic. Pharmacists at the VA make sure that patients can have access to any available medication for their cancer. We can do this here in urban centers by seeing patients face-to-face, but we also use telemodalities to make sure that we can reach the patients at their homes or in rural areas. That really ultimately is what drives me to do the work, is trying to make their days better.
After I started coming here with him on a regular basis to the appointments, I started to really understand the system, just like he did.
And the communication means a lot. I just want to thank the VA for their work and continuing their work.
Good afternoon, everyone. Thank you for joining us today for a Cancer Moonshot panel discussion hosted by the Veterans Health Administration. I am Dr. Erica Scavella, and I have the privilege to serve as the Assistant Undersecretary for Health for Clinical Services and Chief Medical Officer for the Veterans Health Administration. This month is Black History Month, when we celebrate and honor our past, and when we reflect on where we've been and where we need to go. This month also marks the 1-year anniversary of the reignition of the President's Cancer Moonshot Initiative. With this reignition, We are accelerating our efforts to reach the goals of reducing the death rate from cancer by 50% over the next 25 years and improving the experience of people and their families living with and surviving cancer. We must come together to equitably deliver on this promise. But what does this mean? Whether through cancer screening, treatment, clinical trials, or survivorship programs, the cancer care VA provides is not affected by a veteran's gender, race or ethnicity, location, or socioeconomic status. We know that when Black veterans come to VA for their prostate cancer screening and care, they have significantly better outcomes than those using private healthcare services. This is because VA reduces barriers to access that is traditionally seen in non-VA settings. On the other hand, we also know the colorectal cancer screening for Black veterans lags behind that of their white peers, while as veterans as a whole are screened more routinely than their civilian counterparts. Even as we see progress in equity for our Black and other minority veteran populations, we still know there are ways to improve outcomes, tailor treatments, and create positive healthcare experiences. We take that charge seriously, and I take it personally as someone who accompanied my uncles and granddad to the VA for their care, and now as Assistant Undersecretary for Health for Clinical Services and Chief Medical Officer caring for all veterans who come to VA for our care. You'll hear more from our speakers who also take this personally, leaders in VA oncology care, health equity, and the veteran perspective on cancer care at VA. We will be talking about the better outcomes we know our veterans have and on the areas where equitable cancer care still needs to be improved. As we look forward to reducing the mortality rate and improving cancer outcomes through our Cancer Moonshot efforts, we are proud to remain focused on the veteran, their unique risks, their needs, and their outcomes. Now, without further ado, I'm very excited to hand it over to my colleague and friend, Dr. Kevin Stanford, National Outreach and Strategic Partnerships Coordinator for the VA Center for Development and Civic Engagement, who will serve as moderator for the panel.
Thank you, Dr. Scavella, for your remarks. And thank you to our audience, especially our veterans who have tuned in today for this specific event. Before we begin, I'd like to express how humbled we are to honor Black History Month and the reignition of the Cancer Moonshot Initiative by discussing the life-saving cancer care that VA provides Black veterans. Without further delay, I would like to introduce our first panelist for today's event, Dr. Ernest Moy. Dr. Moy is the Executive Director of VHA's Office of Health Equity. His office manages and supports efforts to understand and reduce disparities in health and in healthcare affecting veterans. Currently, the office is coordinating analyses and messaging related to disparities in COVID-19 testing and treatment among veterans. And they are building tools to address structural bias, discrimination, social determinants of health. Prior to joining VA, Dr. Moy served in many leading roles, including leading epidemiology research, quality improvement, and patient safety with the CDC AHRQ. And he was an assistant professor at the University of Maryland Medical School, to name a few of the positions. He started his career at the VA in Baltimore as an emergency medicine physician. Dr. Moy, welcome. And thank you for joining us today. My first question to you is, how can VA prioritize culturally competent care and address unconscious bias?
Well, thank you for the honor of speaking to this group for Black History Month. This is a time to think about where we're at and to think about what we need to do to move ahead to achieve our goal, which is an equitable system where everybody can get the supports they need to achieve their highest level of health, where every veteran can get to where they deserve to go, where they earn the right to go. I wanted to start by expressing some of my biases in response to that question. And to be sure, unconscious bias exists in US healthcare, and and it's something that we need to deal with. We can all benefit from more awareness of how our biases affect others we work with and the veterans we serve, and how we can create a better environment in which to care for veterans. However, to me, the biggest unconscious bias is looking away from the inequities that we see as we deliver care. It is hard to see our veterans not receive the supports they need to achieve their highest levels of health. Again, the heart of the definition of health equity. We are tempted to look away and forget, but we should not. We must suppress this unconscious desire to look away from what is hard. And what we need to do is we need to stare into the face of this hardness and address it. This is the only way we can eliminate health inequities. Looking at inequities and delivering cultural competent care should not be a priority. It should be at the core of everything we do. Stepping back, I see that VA delivers better care than outside VA, and that disparities are smaller, but they exist. And I think many of our quality problems are not about not knowing how to deliver good care and achieve good outcomes. It is about care that works for some and not others. It is about customizing what works for some so that it works for each and every veteran. It is, to me, a fundamental equity issue rather than a general quality problem. And I'm heartened that VA appreciates the importance of identifying and addressing inequities. My office has this as its main goal. We are building equity into policymaking, resource allocation, and care delivery, so it is part of the normal processes of VA. It is our hope that in this way, we can achieve this desired state of health equity for all of our veterans.
Thank you, Dr. Moy. But would you also expand for the audience and tell us what other tools or resources VA is utilizing to close the gap in healthcare disparities?
Thank you so much for that question, because that's really at the core of what my office does. We think that there are three key pillars for addressing health inequities among veterans and for our population as a whole. One thing that we need to do is we need to build that diverse and inclusive workforce where everybody can come in, feel good about the work they do. All staff members can be themselves and speak to each other in a respectful and trusting manner. It's that kind of environment that we can deliver good quality care. In addition, we think that's the kind of environment that is needed for veterans to come and to trust us and know that they will always be respected by us and that we will always have their interests in mind. Building that environment, that diverse and inclusive environment, is one of the things that VA does. And I will say that my office does not lead in that particular area. We support, we provide training and information to help support that particular goal. But the Office of Diversity, of Equity and Inclusion and the Centers for Minority Veterans are ones that lead, and we help. I'll talk about the other two pillars where I think we have more of a strong role. So one thing that we recognize is that many of the health inequities we observe are driven by differences in social risks, the different environments in which our veterans live and work and play. And so one of the things that we do is try to identify those social risks and match veterans with resources to address them. We have a very active program that goes and screens veterans for many different social determinants of health beyond the homelessness and food insecurity that we're routinely screened for. We screen for about 10 different items, including digital divide. And when we identify the social risks that veterans are experiencing, we can then match them up with appropriate resources. If the needs are acute, we can match them up with social workers or digital divide consults to address those specific needs. If they're less acute, we have a process for developing resource guides to match them with different kinds of resources at the hyper-local level. They have to be resources that the veteran can use right where they're at, not something that is a national program, but something that exists in their community, can get them the social supports they need. The third area I'll talk about is we have a number of tools that help providers understand disparities in the care that they are delivering. It goes from the soup to nuts. We look at our data, we look at our quality metrics, we look at variations in our quality metrics across different groups of veterans, and we bring this material back to different clinics and hospitals and providers to identify specific areas where there are disparities. These dashboards can then help them look at and then track these disparities moving forward. We also connect them with interventions, of which there are many that have been demonstrated to be successful to reduce these disparities. And one of the positive notes is that whenever we have done this, whenever VA has said, I'm going to reduce this disparity, it's been successful. And so I'm very optimistic that we will have the ability to do this. We have the resources to do it. It's a matter of the will. Do we have the will to address these social determinants of health? And do we have the will to look at the disparities that exist in the care that we deliver and eliminate them?
Thank you again, Dr. Moy, for the important work that you and your office is doing. Now, we are honored to be joined by our next panelist, Dr. Tanja Thompson, a U.S. Air Force veteran who will share with us her cancer care journey. Tanja retired from the Air Force after 25 years of decorated service. She is dedicated to finding opportunities to give back to her community through her nonprofits and community service organizations here in the National Capital Region. As a two-time breast cancer survivor, she knows firsthand the importance of early detection, treatment options, communication, and self-care. Dr. Thompson is extremely active in this arena. She founded a nonprofit, the Breast Cancer Move Foundation, and is the CEO of the Transformational Resolution Group, and she also authored the book, What to Expect When You Weren't Expecting Breast Cancer. I'm certain this book will answer some of the questions newly diagnosed breast cancer patients and their families may have. Dr. Thompson, welcome. Could you walk us through your cancer journey and tell us what your experience has been with VA through that journey?
Thank you so very much, Dr. Stanford. I really appreciate this opportunity and being here today. My cancer journey has been one, and I coin it as from tragedy to triumph. When I did my TEDx talk, I talked about my journey with breast cancer. And what I remember was sitting there in the doctor's office in 2005 and hearing the words, Sergeant Thompson, you have breast cancer. Just think about 40 years old, just 18 months prior to that, you had a baseline mammogram, and you find out that cancer has ravaged throughout both of your breasts. Those words at that time for me was a death sentence. I didn't know anyone with breast cancer. I didn't even know anyone that has survived cancer at all. And here I am, active duty in the military. And the first thing I'm thinking is that, how do I tell my family? How do I move on with my military career? And one of the things that I would offer to individuals that when you go for a diagnosis such as this, don't go by yourself. I didn't even think or even know about breast cancer. And when I received the diagnosis, I had what is called DCIS, HER2 positive, and it was invasive in the left breast. And the first thing I heard was that I was going to have a bilateral mastectomy. Very fortunately, the doctors, they looked like me. So they understood the issues that I may have been dealing with as far as religion, as far as being silent and not wanting to tell anyone, because I didn't want anyone to know that I had breast cancer. That doctor was a lifesaver. The other doctor was the one who performed the biopsy. And at that particular time, he only had an order to look at the right breast. But he made the unilateral decision to not only look at the right breast, but look at the left one. And the left one is where the invasive cancer was, where it had spread out throughout. I would also like to talk about how very important it is to have those cultural competencies as far as health providers, but also being able to communicate with the patient, but then also the family as well. I can truly say that my time in dealing with the VA has been very positive. And when I hear from those individuals who may not utilize the VA, I ask them to give them a chance, because those doctors, they listened to me, they heard what I was saying, but then also asked very powerful questions to where I was in my life, but then also in my career. So even though I've had it again in 2005 and 2010, I went through the second time. I ended up having chemo and radiation and multiple surgeries. One of the things that I like to offer with that as well is that listen to your patients is paramount, because one of the things that happened right to me right after my surgery was I was denied pain medication. And can you imagine having all of your breasts removed and right after surgery not getting the pain medication that you needed? I felt like my skin was on fire. But fortunately, there was a doctor there that stood up for me and said, give this woman her pain medication. So, as we talk about health equity, as we talk about those social determinants, as we talk about the culture, especially when we're talking about people of color, African Americans more specifically, there's a lot of things that we don't understand, especially in that communication. So it's paramount that we have that communication with our healthcare providers as patients and being able to feel comfortable in building those relationships and having trust in them when we are in a diagnosis where we feel that is a death sentence.
Wow, thank you for being so transparent and telling your story, Dr. Thompson.
Thank you.
Breast cancer has affected me personally, sorry about that, through my grandmother, my mother, and my sister-in-law. So I'm glad we are discussing positive treatments and outcomes. Before we go to our next panelist, is there anything else you want your fellow veterans to know about cancer care at VA?
Actually, I do. And I actually, because I didn't want to forget anything, I actually made a list. And a lot of these services I have actually utilized. So the Women's Veteran Call Center, as well as the Center for Women Veterans. I've actually done work with Hampton Roads, Hampton VA Medical Center, as well as Fort Belvoir Medical Center, the Minority Veteran Care, as well as mental health. That is one of the things that really helped me as I was going through this process. I didn't, I felt ashamed and I didn't want to talk about breast cancer because truly, honestly, I thought I was being punished. So being able to talk to a healthcare provider about what some of my concerns were really helped in my mental awareness and my mental ability. And to why I started the Breast Cancer MUA Foundation, where the tagline is breast cancer bugs me, is because we need to have those opportunities to talk about breast cancer, especially the early detection. And I actually have a beetle bug card that I drive around that has positive breast cancer affirmations on there. So as I may not be talking to people directly, seeing the card, either for a man or a woman, you will, hopefully it will trigger something to say, hey, I need to get my mammogram. I need to go in for early detection. I need to talk to someone if I feel something, see something, feel something, just by seeing this card. So it's a beetle bug breast cancer card with positive affirmations.
Thank you again, Dr. Thompson. I would love to see that card. Thank you for your advocacy and your encouragement to our veterans. So now, let's hear from another veteran, Mr. Eric Jones, who served in the U.S. Army, and he is a Bronze Star recipient. He's joined today by his lovely wife, Mrs. Monica Jones. Mr. Jones is currently in maintenance treatment for metastatic lung cancer. Mr. Jones, could you walk us through your cancer journey and tell us what your experience has been with VA throughout that journey?
Yes, good afternoon. In relationship to Dr. Thompson, I can relate to everything that she has said. And I really mean that. My journey was a little different, but at the same time, we got through it with a lot of support. I first went there and I told my wife I wasn't feeling well. She said, well, come on, let's go. And I said, well, I want to go to the VA. I had been going for the last 20, 30 years. She said, nah. So I convinced her to go. And that's where our positive journey has started. And it's been positive ever since. We've had a great, you know, oncology and all those things were new to me. I was a little devastated about uh, knowing that I had stage 3 cancer. And I was even more devastated to learn that I had brain cancer. So, um, which led me to stage 4, which I'm finding out now that my treatment had to be a little bit more aggressive. Well, that's where my wife came in because, you know, she picked up some things that I wasn't able to really comprehend. I was taking the treatment and she made me go every time, every day. And that support was really enlightening, really was helpful in getting me through this journey. I'm maintaining now. Uh, and I also want to mention that the VA, you know, it's not just oncology or hematology, it's a whole team. I have the nurse practitioners, I have the pharmacists, I have the nurses. You know, the infusion part is necessary, and so is the radiation. So it's a journey, but I'm here to testify and give you my testimony that I definitely got through it.
Awesome. Before we move to the next panelist, is there anything else you want your fellow veterans to know about your cancer care at VA?
Yes. Don't take things for granted. I'm a Vietnam veteran, and I've been going there so long. I see where the eras have changed, the war eras, and as African American, also we have certain things that we have to be on top of versus other, uh, um, you know, things. So I encourage them to really check out the VA. You know, they had me in surgery the next day after I was told that I had brain cancer. Oh, whoa. So, and up until this point, it has just been a gratifying experience, and I'm here to give you my testimony. So I encourage all these veterans to come on, man. Let's do this. And it's a healthcare system that I never realized. It's a great healthcare system.
Well, thank you both for that. And with that, I'd like to introduce our next panelist, Dr. Isla Garraway. She is a surgeon scientist, professor of urology, director of research, member of the Johnson Comprehensive Cancer Center, and a member of the Broad Center for Regenerative Medicine and Stem Cell Research at the David Geffen School of Medicine at UCLA. She maintains a clinical practice with the Greater Los Angeles VA healthcare system, where she currently advises and leads efforts in the Precision Oncology Program. She leads the Cancer of the Prostate and Genital Urinary Cancers Program and ensures equity within VHA's role in the Cancer Moonshot Initiative. Dr. Garraway, what does health equity mean to you in your practice?
Well, thank you so much, Dr. Stanford. And it's a pleasure to be here today and be able to express my experiences with the panel. So I'm going to echo what we've been hearing this morning from the other panelists, which is the essence of equity is ensuring that our richly diverse VA population, who come from different backgrounds and have different experiences and varying levels of resource, have what they need to stay healthy, and also to treat the medical conditions that they experience if and when they arise. So, as you pointed out, I'm a urologist, and urologists are often on the front lines of diagnosing and treating prostate cancer, which is one of the most common cancers affecting our veteran population and also a leading cause of death. So, The really good news about equity related to to prostate cancer in the VA healthcare system is that Black veterans do not appear to be diagnosed with more advanced disease or experience worse outcomes than other populations. And this is a welcome contrast to what we see in other national trends. However, Black veterans do continue to display an increased risk of developing prostate cancer. So it becomes so important for us to provide education about screening for prostate cancer and early detection. We aim to engage with everyone involved in the care of high-risk individuals, including our Black veterans. And that means talking to and engaging with primary care providers and the patients and their families who can advocate for discussions about if screening for prostate cancer is right for them and when screening should start. So to achieve health equity, we are really focused on providing awareness to the veteran populations at increased risk, including Black individuals, and improving outreach and communication surrounding screening, early detection, and treatment choice. In addition, we are really focused on ensuring that VA care is even more accessible by providing remote options such as video visits and telehealth, and enlisting cancer care navigators to help follow up with our patients, make sure they can have their questions answered, and that their management plans are being implemented.
Thank you, Dr. Garraway. But with those comments, I'd like to also ask you to expand on how the Reignited Cancer Moonshot Initiative has impacted the veterans you serve. And what can veterans look forward to in terms of treatment, innovation, or in any other ways?
Well, the Cancer Moonshot 2.0 is so inspiring to the network of physician scientists like me in the VA. So in addition to the mandate to address health inequities, which is of course part of Moonshot 2.0, we are also focused on the mandate to target the right treatments to the right patients. And this is a concept that we often refer to as precision medicine or precision oncology. So this means discovering whether there are mutations in cancer-related genes that could make cancer cells more sensitive to very specific targeted medical therapies. And this approach really allows us to personalize the treatment choice for our patients as we attempt to, prolong life and improve quality of life. So the VA National Precision Oncology Program has developed so many tools for providers like me that we can use to make sure that patients with prostate cancer who may be eligible for precision oncology get the testing that they need so that they can be identified and the treatments can be offered. And this has resulted in many veterans being able to access the most state-of-the-art precision oncology therapies available today.
Thanks again, Dr. Garraway, and thanks for leading those efforts. Now, finally, I'd like to introduce our last panelist of today's event, Miss Jade Brooks. Jade Brooks is a thoracic cancer nurse at the Magnet Hospital, the Michael E. DeBakey VA Medical Center in Houston, Texas, where she works with our National Tele-Oncology Service as a coordinator. Most recently, Ms. Brooks was a VHA Diffusion of Excellence Fellow, which further demonstrates her commitment to modeling high reliability in her care delivery, and how she is being an important connective thread for veterans and our facilities. Ms. Brooks, welcome. Can you describe what a tele-oncology coordinator is, what their role is, and what their relationship is to the veteran?
Absolutely. As a National Tele-Oncology Care Coordinator, we serve as a liaison both between the provider and the facilities they serve. In regards to the Moonshot Initiative, we understand with the National Tele-Oncology Program that we are delivering cancer care to rural and marginalized areas. We're bringing specialty care to the veteran that normally is not within their foresight to reach. So in this delivery, the coordinators, we are managing care across multiple state lines. We're tracking things diagnostically that need to be there to make sure that they receive the best treatment and evidence-based practice as possible. With National Tele-Oncology, one thing that we are also doing, we're doing clinical research, clinical trials, and we are addressing disparities that we know have been perhaps attributed to some of the disparities related to systemic biases and also barriers of care.
Wow, thanks, Ms. Brooks. Of course, I'd like to ask you a follow-up question as well. From your perspective as a nurse and a tele-oncology coordinator, what would you want Black veterans to know if they're hesitant about receiving cancer care at VA?
Is that we understand. I think that it's very important to acknowledge how did we get here, the prejudice, the systemic biases, and what are we doing now to move forward? One thing that was mentioned by several of the panelists is that we are a large integrated, in fact, we are the national largest integrated health system. So in doing that, we've taken the responsibility of ensuring that we have a diverse workforce, that we are culturally competent, that we're delivering specialized care that was at one point in time no longer within their reach. In regards to colorectal cancer awareness, which is next month, we have to address the fact of knowing that many Black veterans are often diagnosed late. 1 in 20 will have a diagnosis of colorectal cancer. So in doing that, increasing education, increasing screening, empowering our veterans to understand that the VA, we have came a long way. We hear you, we understand you, and we're working with you.
Wow. Ms. Brooks, thank you again. Now, as we have a few minutes to spare, I'd like to follow up with our veteran panelists and ask them a couple of questions. I'm going to direct my first question to Mr. and Mrs. Jones. What other ways can VA use available resources to help provide equitable care? Mrs. Jones, please feel free to share your thoughts on the cancer journey thus far as well.
Yes, I'd like Mrs. Jones, Monica, to address some things here because she saw a lot more than I saw. So, go ahead.
Well, thank you so much for that question, and thank you for the time that you've given us today. And this is certainly a very, very important topic and one that is very much appreciated. As my husband mentioned, I was a bit leery about the VA at first when he received his diagnosis, or even before he received his diagnosis when he became ill. But after our experience, I am 100% an advocate for the VA medical center, the VA health system as a whole, I'm telling you. So I would certainly continue. Several of our panelists today mentioned several words that resonated with me, including Dr. Moy with support and workforce, and Dr. Thompson with don't go by yourself. That was a major, major piece of our journey. And I felt that my support helped my husband to get through what he had to get through, because there were days, and I saw this with not only my husband, but with other veterans who were there by themselves. And I often wondered, how do they even get through this? If they're here by themselves, then they're hurting, they're ailing, not feeling well, and the medical professionals are giving them this information. How do they go home and process this and be able to follow through on what it is that they need to follow through on? So with that, I am hoping that the Veterans Health System and the Veterans Administration continues to build on the social services that were mentioned earlier, especially by Dr. Thompson, and some of the other resources that are available to help our veterans between their visits, to help them to be taking care of themselves, taking their meds, doing all of the things they need to do. And additionally, and I'll, in closing, I will say that I would certainly love to see the Veterans Administration do some outreach via public service announcements and by intentional media advertising. Intentional media advertising, I've heard a little, but I think that will help to inspire and help to move the needle on what you're trying to do with this very important topic and issue.
And I also would like to give a shout out to all my nurses. The team is phenomenal at the Philadelphia VA. Dr. Parikh, I just wanted to throw a little shout out there and look forward to doing this again.
Well, thank you both for those insights and the advice, and I'm sure the team appreciates all that you've said about them today. So now to my final question. It is to you, Dr. Thompson. What else would you want veterans to know about cancer care at VA?
Thank you for that. And to answer your question, Mrs. Jones, how did I get through going the first time? I didn't. I only approximately heard 10% of what was said. So when I went back home, I was jelly. I was jello. Mm-hmm. And fortunately, the VA doctor said, I see that you're here by yourself. If you need to come back with your husband, I will make time for you. I will prioritize you and your husband coming. She said, because I don't know how you're even able to go home. So that's the answer to the question. I heard little to nothing. But to answer the question, one of the things that I have been a part of, and that is clinical trials. In order for Black and Brown African Americans to truly get the targeted treatment that we need us to participate more in clinical trials. I've participated in approximately 3 clinical trials, but that's because either I'm on the list or someone reached out to me. One of the things, I don't have a problem running my mouth, so people reach out to me. So we need to be able to reach out to our veterans. We need to reach out to our community and find ways to tailor that conversation, tailor that communication, so that our veterans, our military that are still serving, participate in clinical trials. I know as an African American, the first things that come into my mind is all the mistrust that is in our community relative to health providers, our health professionals. But I feel that the VA has done a wonderful job in looking at those social deterrents, looking at the cultural competencies, looking at the cultural communication that is needed to be able to communicate with our veterans, because we see people that look like us. And when we see people that look like us, we have more of a tendency to feel comfortable in having those conversations, because we know that those individuals are more in tune to listen. And one of the things that my grandmother used to tell me, she says, Tanja, you have 2 ears and 1 mouth. You need to learn to use them in proportion. So I take that as we go forward, and going forward, that our providers need to do more of this and less of this, because this is truly where the transformation happens, is when we truly take the time to lean in and to listen to our patients, not just the words that they're saying. So thank you.
Thank you, Dr. Thompson, for that great insight and that wisdom from your grandmother that we surely can use. And now, with that, our presentation has come to a close. I'd like to say thank you to all our amazing panelists today for your inspiring stories, as well as your dedication to providing equitable cancer care at VA. We're glad to have had this opportunity to share this information during Black History Month. Happy Black History Month to our Black veteran community in particular. On behalf of VA, we want to remind all veterans that they are strongly encouraged to talk to their VA provider about the need for different cancer screenings and to inquire about what screening options are available to them. If you would like more information about cancer care at VA, visit cancer.va.gov. For more information on the Cancer Moonshot Initiative, visit whitehouse.gov/Cancer Moonshot, and that's all one word. Thank you all for joining us on today's event.